Okay, friends, you are so much welcome again today for this very interactive section. I'm so confident that it's going to be so much interactive and so much to learn. And there is no any other expert that we can talk about today or to guide us today in this discussion other than Professor Williams, who actually did a good job in the previous session that we had on child development. Like I said during the previous section with him, and I gave a brief introduction about his profile, he indeed has a very long profile. So we'll have time to engage him regarding career development, where we can explore his profile, ask questions about his achievements, and we'll try to conserve this much introduction till in the next few days when we do that. And affiliated with so many universities in the United States. So I'm just going to mention a few of those universities he has worked with: Dayton University in Ohio, Wright State University, Linda A. Cohen Center for the Study of Child Development, and where he's currently a director of research. He has also worked with the Nova Southeastern University in Florida, University of Texas, that is Pan-African University, and also University of Mary Harding, Ballon, Texas, and Texas A&M University. Professor William also has won a lot of awards that include Outstanding Early Childhood Teacher Educator of the Year by National Association of Early Childhood Teacher Educators, Exceptional Service to Refugee Community by the Rwanda Committee of Dayton, Humanitarian Service Award, Humanitarian Service Award for B grade as well, Joint Service Commendation Medal, Joint Service Achievement Medal, Meritorious Service Medal, Bronze Award for Scholarly Writing, Award for Excellence in Scientific Writing, and also being an academician and a researcher, he has authored more than 20 book chapters and books, and with several publications as well in peer-reviewed journals. Also, it is delightful to mention that Professor William also speaks, he writes, and he also understands Spanish and Portuguese language, and as well, he has a good understanding of Turkish language. So it is also my privilege, and I'm indeed excited again to welcome Professor William to today's session. Prof, you are welcome.
Thank you for having me.
You're welcome, Prof. It's always a privilege, Prof. Yeah, Prof, today we will be having a discussion on the topic that is very common and we believe will be very informative to everyone out there, which is about drug use, drug abuse, or we can say drug misuse. And Prof, the first thing that you will try to guide us through is about misconception on the use of drugs. Okay, and when I say the use of drugs, I talk about prescribed and unprescribed medications. So we will really love your insightful comment about it. I mean, how we can easily be informed on the difference between drug use, the misuse, abuse, and addiction. Thank you, Prof.
Okay. Well, both the terms misuse and abuse of drugs are intimately tied to the issue of substances that have addiction potential and therefore can be harmful to the body and potentially life-threatening. Addiction is a psychological and/or physiological condition of the brain that is caused by the brain anticipating more of the substance to be able to maintain homeostasis. What does that mean? The substance of abuse happens to have within its chemical compound neurotransmitters that can activate the brain in such a way as to produce a habituation, the brain thinking that I need to start making the person feel depressed or irritable so I can get more of that drug. Classic example is addiction to tobacco. And the interesting thing about addiction and addiction potential or misuse of drugs, whether prescribed or over the counter, or some substance like alcohol and tobacco, is that everybody's not predisposed to substance abuse. Most people think anybody can become addicted. Not really true. Yes, there's an outside chance that if you give a person a high enough dose of morphine or an opioid compound, they can become addicted. But most people will not become addicted. People who have an addictive personality have a certain type of liver that metabolizes substances that get sent to the brain differently than perhaps you and I. And the classic example, again, I will frequently in today's talk go back to tobacco use. It's not the nicotine in the tobacco that's the problem. It's the 240 teratogens that happen to be in the tobacco smoke that can cause cancer, for example. Nicotine can't cause cancer, just like caffeine can't cause cancer. Or the caffeine that's in chocolate that's called xanthine. They're all psychostimulants. So the difference between chocolate and cocaine is just a side chain difference in terms of molecular structure. So people get really confused about this whole concept of drug abuse and drug misuse.
Thank you, Prof. That is very important, and because, and I think briefly you actually attempted to mention some of those causes of drug misuse and drug addiction. And is it possible you can expatiate on these causes? Because I think it is good to have the information about the causes of these so that in order to be able to solve the problem of drug use or drug abuse or drug addiction, and that will be quite easy to handle if the causes are well known to people.
Well, I don't know about it being easy, but addiction, the word addiction has a definition. It's a chronic, relapsing disorder characterized by compulsive drug-seeking behavior, compulsive drug-seeking use, despite of adverse consequences. And to go back to drinking alcohol, the person might start drinking occasionally, and then they start drinking every day. And then it interferes with them getting up to go to work. And then there's no income flow of money, so that then maybe they have to start borrowing money to get alcohol. It's the same thing no matter whether it's an illicit drug, that is an illegal drug, or alcohol or nicotine, tobacco. So the brain sees this concept of addiction as a disorder. It's a disorder that involves changing the way the brain circuits are involved in terms of the reward receptor sites, the stress response receptor sites, and self-control receptor sites. And those changes that happen in a person can be lifelong. In other words, that's why I carefully use the term frequent relapsing. The average cigarette smoker, the average alcoholic, has quit a minimum of 7 times before they actually become sober or stop smoking in the case of cigarettes. So even when a person stops for a while, I've had many patients who've said, oh, I was able to stop smoking for 2 years, and then the craving came back and I just started smoking again. Or the same thing with alcohol or opioids, any other substance of abuse. And the dilemma is that when people think about those sensations of intense discomfort, that is an abnormal stress response because the body's craving the substance, the dopaminergic circuits saying, wait a minute, I need a reward, and this substance gives me that reward. Then they have a hard time with self-control to stop from indulging, because those 2 receptor sites, the ones for reward and the receptor site for feeling less stressed, happen simultaneously.
Yeah, Prof, thank you so much. Yeah, you know, while you are trying to give your that distinction, and you often mention about cigarette addiction and alcohol addiction, at the same time drug misuse. Is it possible to have a clear differences between these, and especially in the term of damage? Okay, what level of damage are associated with these categories of substance use?
Well, this is a fascinating question you've raised, because most people assume because cigarette smoking is legal, because alcohol drinking, even though it's frowned upon in religious circles, still it's legal in most countries. Not legal in Tunisia, but in most countries it's legal. And so people just assume that cigarette use and alcohol use is less potentially damaging to the brain than the illicit drugs, the illegal substances. And actually, in fact, that is not true. Example, if a person is a 2-pack-a-day cigarette smoker, positron emission tomography studies of the human brain demonstrate clearly that people who are chronic cigarette smokers, who have smoked cigarettes for 20 years, 2 packs a day, their brain actually shrinks, which impacts cognitive ability. So there's a higher percentage of people who were cigarette smokers or alcohol drinkers who develop dementia in old age compared to those who are not alcohol drinkers or cigarette smokers, who, when they're senior citizens, do not develop dementia. It is a very common misconception that, oh, as you get older, you get absent-minded and become demented. That's not the norm. That is not the norm. About 1 in 4 senior citizens will develop dementia, not all of us, not everybody. Now, 25% of senior citizens having dementia certainly is such a high percentage that that's why it's so easy for us to think that, oh, as you get older, everybody loses cognitive ability. No, as you might remember from when you were one of my graduate students, in one of my test questions on the final exam was a question about, is dementia common in senior citizens over 65? And the answer is no.
Really?
The average senior citizen actually has better ability to think as they get older. It's just because it's in all the movies and on television programs, people
Really?
assume that senior citizens always end up being
Dementia patient.
demented, but it's not true. So let's talk for a moment about what might be labeled a difference between cigarette smoking and abuse of other drugs.
Yes.
People seeking treatment for alcohol abuse or drug dependency for the opioids or even for cocaine abuse are asked about the difficulty of quitting the use of that substance compared to quitting cigarette smoking. 54%, over half of the people who are addiction to an opioid. And brain research bears that out. This is confirmed that nicotine addiction is so difficult to overcome because in 7 seconds after one takes that puff of a cigarette, within 7 seconds, the pleasure center of the brain is stimulated and the relaxation center of the brain is stimulated. That's a powerful double whammy for the brain. So it's not impossible to stop smoking, but it's difficult to stop smoking for most smokers.
Prof, this is very interesting because I think then several years ago, where I had good number of friends who were good smokers, and I think I remember maybe twice or thereabout, and I went out with them to party, and they were smoking, and I excused one of them with the cigarettes, and I did actually tasted that. And one of the things I found is that I want to compare this. I want to make a personal illustration. For me,
Yes.
I love to take juice, beverages, for instance, because of the sweetness. Okay, so yeah. So when I tasted the cigarettes and alcohol at the same time, you know, the alcohol taste is never sweet. The cigarettes too, for me, I'm talking about my own perception. For cigarette too, I couldn't find any justification to engage in that. So yes, so that kept me wondering, Prof, why people get addicted to such substance. I mean, because I want to believe, for my own personal illustration, that if I'm to be addicted to something, I should.
It should taste good.
It should taste good, for instance, and I should feel comfortable while doing that. So
yeah, that isn't how addiction works. That isn't how addiction works. The reason I said 1 out of 4 people on the planet have a predisposition genetically to substance abuse. Most of us don't. Oh yeah, if some Taliban extremists decided to kidnap me and take me to Afghanistan and pump my arm full of opium, okay, theoretically, I would become physiologically addicted, but not psychologically addicted, because I don't carry the gene. I don't carry that predisposition. So it would take time for me to deal with the withdrawal symptoms, but I wouldn't stay an addict. But that's kind of a movie scenario, you know, TV show or movies, right? That tends to not happen in real life. People get addicted on their own. And the people who get addicted, it isn't because it tastes good. It's because if you have a liver that metabolizes nicotine in such a way that it goes to the brain and replaces nicotinic acid, which is a normal metabolite of the brain, the brain thinks, oh, we're short on nicotinic acid. Here, we'll just use this. See, the difference between this normal metabolite in the brain, nicotinic acid, and nicotine, I mean, why do you think chemists name substances with such a similar name? Because they're similar substances. The difference between nicotine and nicotinic acid is only a side chain difference of how the hydrogen and carbon atoms happen to be compounded in that substance. So when a person takes that puff, it goes to the liver, it goes through the lungs, into the liver, then quickly up to the brain in 7 seconds. The brain is thinking, oh, here's a supply of nicotinic acid. So in other words, the kinds of people who tend to get addicted are people who carry the gene for less nicotinic acid in their brain. And those are people who are predisposed to depression. Now we can see this on imaging of the brain, MRIs. When we look at different brains that have potential for addiction and brains that seem to not have addiction potential, there are significant differences in the brain, in the blood flow in the brains. So this is not to say anything negative about the individual who happens to have the bad luck of carrying the gene for substance abuse potential. I'm just simply clarifying how come it doesn't happen to all of us. So it didn't happen to you because your liver doesn't think that nicotine is nicotinic acid and is supposed to send it to the brain. Same thing with my liver. You know, because my dad grew up as a two-pack a day cigarette smoker as a truck driver. When I became 18, I experimented to see what it was like. And oh, this is horrible. Oh my God, this is, and I said, I have no idea what he finds interesting about this, but it's not for me. So that means I didn't carry the gene for needing more nicotinic acid in the brain. And nicotine is an efficient way for the body to replace nicotinic acid. So unbeknownst to the addict, they're using chemical replacement therapy on themselves just to treat their depression, even though they would never admit that they carry the gene for depression. The average alcoholic never admits that they have depression. I've treated, well, if it hasn't been 1,000 alcoholics by now, it's close to 1,000 people with substance abuse over the years. And at the clinic, at my clinic, and the answer always is, oh, I'm not depressed. because they think the word depression means sad, and they're not sad. They're just angry all the time. Well, anger is a way of hiding your depression. It's a substrate of depression. In fact, in the Diagnostic and Statistical Manual for Depression, the number one symptom of depression, we have a list of 14 criteria, and if you meet 6 of them, that means you carry the gene for depression. And the number one on the list is not sadness, it's anger. Do you get explosive easily? Aha. So that's a thought.
That is really, really informative, Prof. Because the issue of drug use disorder, it's really a global issue. Yes, and and it's generating so much concern. I read a piece, maybe I should read that to you, that was put up by the United Nations Office on Drugs and Crime, that is UNODC. So UNODC reported that there were reported 275 million drug users last year. Yes. And out of these numbers, 36 million people were found to be having this challenge of drug use disorder. And when I did the statistics, I found that this is about 13%, which is so significant.
Yes.
Yeah. And that brings me to this question, Prof, because across the globe, United States happens to be one of the countries with this enormous challenge of drug
substance abuse.
Substance abuse. Yeah. So, and not only United States, and in some many parts of the world as well. So I want to ask that why do you think it's really a serious challenge for countries like United States with enormous wealth and finding it difficult to fight or to combat the use of illicit drugs?
Well, I think the principal reason is because of the societal stigma against mental health issues. There is a huge stigma in all societies. I certainly find it here among the Islamic community, the stigma about maybe there's a member of the family who's they consider themselves a very devout Muslim, but they're a chain smoker. Well, and that's in the Quran. Muhammad wrote that you're not supposed to smoke. So you can't quite call yourself a devout Christian, Muslim, Jew, whatever, Hindu or Buddhist, if you have this craving you can't control. And the issue that I bring up to patients frequently is, well, you got to stop beating yourself over the head and also stop lying to yourself, because this is a mental health issue. This is not an addiction issue. And until society destigmatizes mental health conditions, in other words, diseases above the brain, above the neck. See, if you or I have heart disease, you or I have diabetes, well, maybe we don't like the idea of taking medicine, but you don't want to die of a heart attack. You don't want to die of type 2 diabetes and have your legs cut off because of poor circulation. So you might agree to go on medication. But as soon as one talks about diseases above the neck, unless it's seizure disorder or cerebral palsy, people have this unwillingness to acknowledge that the brain is just like every other organ in the body. It can have disease, and it's not bad to have a mental health disorder. It's just the luck of the draw, because almost always, 93% of the time, it's genetic. It's not caused by stress in your life. It's caused by genetic predisposition. So the wisest solution to solving this worldwide problem of substance abuse is to destigmatize mental health issues and expand mental health services to assist people in understanding that addiction is just a way of them dealing with their chronic anxiety or chronic depression, even though they don't realize it. They're just self-medicating to control their anxiety disorder or their depression. And self-medicating with a drug.
Yeah, Prof, thank you so much. The response you just gave now, I think it's quite, okay, let me just mention this. In my country, in Nigeria, we also have this serious challenge for the past few years now. The issue of substance abuse has been very, very serious one. And as a country also, we do have an agency that is responsible for to combat the substance use and abuse across the length of the country. And the director, who is the head of the agency, once made a statement about a few months ago, which I just want to paraphrase. And because of the endemic situation, because of the serious situation of this challenge in the country, he suggested that the government should look into adopting a policy that will tends to check or test intending students into universities, and for alcohol level, drug level, substance level, to test, I mean, have a general blood test to control for drug abuse. And at the same time, he also recommended the same for political office seekers. Now, in your last response, Prof, if I'm to relate this, it means that there is likely, such policy might likely to be inefficient if I'm to take your last response.
Right. Yeah, drug testing is not the answer. It is definitely not the direction to take. The solution to the problem of substance abuse will not be solved if we continue to have individuals who have addictive personality. So if you have an addictive personality disorder, then whether you're smoking tobacco, drinking alcohol, or then going on to another substance of misuse, it's mixing apples and oranges. To address this kind of a social problem, the problem of substance abuse in society, we need to address the fact that alcohol and tobacco are also substances that get misused. And you can understand how complicated that would be to try and regulate that. Think of before you and I were born, during the, right after the, before the Great Depression, in the World Depression of 1930s, there was in the 1920s a law against drinking alcohol in the United States. And due to that, alcohol use became higher because it was prohibited. So people then wanted to use it, so they would go to places to illegally drink. So the answer is definitely not drug testing. It will not work because the issue we're dealing with here is an obsessive compulsive tendency, which is related to one's personality, not the particular drug of choice.
So, Prof, can I just ask this question directly then? That means that will you recommend the medicated use of substance, for instance, like opium, medicated use of?
Nope, I don't. No, I recommend, you know, because I was in practice in Florida, where that's very common, and in practice in Texas, where that's very common, there would be people who would come to the office regularly to want to get their fix as a maintenance dose. And I would say, I don't ascribe to that approach to substance misuse. You have an underlying depression, and we need to treat your underlying depression. And then the person frequently would get defensive and say, I'm not depressed. Then I would clarify for them, guess what alcohol is in terms of chemistry?
Yes.
It's a depressant. Guess what opium is in terms of chemistry? It's a depressant. It means it depresses the central nervous system. So if you already carry the gene for depression, it's going to make your depression worse to drink alcohol or to take any opioid substance. That was one of the insane things about the, I guess maybe it started 30 or 40 years ago, people mixing opioid compounds with methamphetamine. So why? Because one is a downer and the other is a psychostimulant. Like chocolate's a psychostimulant, like tea and coffee are psychostimulants. So the depression is less intense in the opioid compound if you add a psychostimulant like cocaine. Well, so that's why it became more addicting, and that's why there are a larger percentage of people who are addicted in modern times, because then they don't just feel down, they feel full of energy and depressed, which is not healthy at all, because it leads to much more drug-seeking behavior.
Thank you also, Prof, for that. You know, and I'm so much interested in this particular topic because it's currently it's a serious issue in my country.
Yes.
And, yes, and I know quite a number of countries across the globe that are experiencing the same terrible situation. For instance, Prof, marijuana is illegal in my country.
Yes.
Okay, and but the use of it is actually escalating.
High.
Yes. So year by year, the use of it is really increasing. And one of the governors in my country suggested that, not even suggested, he was on the verge of starting a policy to have a plantation for marijuana.
To legalize
marijuana.
Right.
Yes. And because, you know, there is also the economic aspect of it, you know. So if it's been legalized, that will also serve as a another source of revenue to such government.
Absolutely. See, if we compare the effects of cannabis and the effects of nicotine, cannabis is no more dangerous than nicotine. Since nicotine is legal, and I'm not advocating it legal or illegal, I'm just saying since it is legal, then it makes no sense for cannabis not to be on the same level, since there's no physiological addiction to cannabis. It's only the psychological addiction, cannabis. Whereas with nicotine, there's a physiological addiction as well as a psychological addiction.
Now I perfectly understand these two dimensions now, really. Okay.
But smoking any substance is bad for the lungs.
Thank you so much,
Bro. It isn't just the THC in the case of cannabis or the nicotine in the case of tobacco. It's those substances that are in there that create chemicals from the smoke that then go into the lungs and damage brain cells, damage lung cells.
So, Prof, what then is your advice to a sufferer of drug misuse and addiction?
Good question. If I'm asked by anybody on the street or at church what my advice is, I say seek treatment, seek help, seek support from Alcoholics Anonymous if it's alcohol, or Narcotics Anonymous if it's a narcotic. Or, you know, I have worked with many substance abusers, and I've never met one, of the close to 1,000, if it has not been over 1,000 yet, of the hundreds and hundreds of substance abusers I've worked with, I've never met one who didn't also smoke cigarettes. Never one. They always are cigarette smokers. If you go to an AA meeting, an Alcoholics Anonymous meeting, which I support Alcoholics Anonymous, they're a very good organization to help people control their use of alcohol, or Narcotics Anonymous, there's always a smoke-filled room. Everybody in there is smoking their cigarettes. And why? Because they're still depressed. They're just no longer using the alcohol or the narcotic. And so they're using the nicotine to replace nicotinic acid in the brain, which stimulates norepinephrine, which stimulates serotonergic neurons, which then gives the person a feeling of happiness, less depression.
So the number one and most likely the best and only advice is to seek help.
Yes. Yeah.
Because
seek help for the underlying problem.
Problems, yes.
The underlying problem is a mental health issue. But the society has such a stigma against anxiety disorders. We even call them that. We call them disorders, which freaks people out. You know, if you have heart disease, people don't get freaked out. If you have diabetes, people don't get freaked out. But as soon as you hear the word
mental
depressive disorder or anxiety disorder, people think, what? I'm not anxious, I'm not nervous, or I'm not depressed. They get defensive. It's a problem. So seek help for the underlying problem that is not your fault. That's the whole point. It's genetic. Inherit it from your mother's side of the family or your father's side of the family, or in the Muslim community, because 45% of Muslims marry cousins. That's a huge percentage. It might run on both sides of the families, and then you got a double whammy for that depression or anxiety disorder.
Thank you, Prof.
And remember, in Nigeria, northern Nigeria is obsessed with being Muslim. And so there's a lot of marrying cousins.
Yeah, Prof, you just mentioned a very interesting one because in our demographics in Nigeria, the use of
Yes.
substance is highly prevalent in the north.
Yes. Yes, I
Highly.
know.
Oh, really? Okay.
Yes, and that's the irony with
Mm,
all the religiosity, the
mm,
obsession about religion, and
mm,
yet people are hypocrites
mm,
because they force the women to
mm.
be subservient to men instead
Yeah.
of realizing men and women are equal. And
Mm,
then they also imbibe in substances
mm,
because they aren't willing to accept that what the underlying problem
mm,
is a gene for anxiety or a gene for depression. And if you
mm.
treat that with
Yeah.
non-addicting
Mm.
medicines that you get from a pharmacy,
Yes.
they're non-addicting. Prozac is not addicting,
Mm.
but people want to say, oh, I don't want to take drugs.
Mm.
I'm not going to take drugs. I'm not going to take drugs as they smoke their cigarette.
Mm. 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 I see. Oh my God. Prof, thank you so much for this enlightenment. This piece of information is actually huge. And I'm so very sure that for every viewer who will watch this, they will find it interesting and educative as well. Prof, I will ask you one last question.
Yes, sir.
If you can give a general perspective as regard what your advice should be to the society, okay, regarding how to overcome, maybe not overcome, that is not a good word to use because maybe we can possibly not, we might not be able to overcome it, but rather how to address it, yes, how to address this tumultuous issue of substance use and abuse across the globe.
And it's what I've previously stated. The issue is that internationally, in line with the United Nations, the United Nations has already made an attempt to destigmatize mental health disorders. We need to help people understand that diseases above the neck are really no different from diseases below the neck. For some reason, because we think with our brain, we feel with our brain, we tend to assume that I can control my anxiety or depression with willpower. That isn't how it works. It doesn't work that way. I can honestly admit when my ex-wife, I mean, I thought I was the luckiest man in the world. We had 6 kids. I was happily married, I thought, for 20 years. And then after 20 years, when my ex-wife said, I don't love you anymore, I like this 26-year-old guy better, I was heartbroken. And it didn't stop me from being a productive professional. I still kept publishing my research, still kept doing my university lectures, still kept seeing patients. But it was tough for a year, for that first year. It's been 2 years now. And that's why I came to Istanbul, because the pain was tremendous. But individuals who carry the predisposition genetically for an anxiety disorder or a depressive disorder have a harder time coping than those of us who get sad because our mother dies. My sister died of COVID last October. My older sister. I was sad to lose my sister. When my mother died, oh, I felt horrible. However, because I don't carry that gene for depression, it didn't overwhelm me. I was just very, very sad for a few weeks. but then I was able to bounce back because I don't carry that gene. And better living through chemistry is the answer for a person who happens to have difficulty bouncing back from stress. And the better living through chemistry is not found in substance abuse, alcohol, or marijuana, nor cigarettes, but rather an antidepressant, because there's no such thing as an addicting antidepressant. That's the insanity of substance abuse. People say, oh, my body's a temple. My body's a temple. I'm not going to take a drug for my depression. As they're smoking, they're talking to me while they're smoking, telling me that their body is too pure to take a drug created by a pharmaceutical company to control depression. So the way to help society is to destigmatize the whole idea of the diseases above the neck. If you or I had seizure disorder, we wouldn't have any problem accepting seizure medicine. That's a brain disease. But as soon as we talk about anxiety or depression, somehow people flip a switch and say, oh, that doesn't count. That's not like the problems with GABA-aminobutyric acid related diseases that we call seizure disorders. No, mine's related to norepinephrine and serotonin, and so I can do it with self-control. No, it doesn't work that way. If one's has a family history of Alzheimer's, you don't want the family member to have their dementia get worse and worse and worse and worse. So you go on a Lewy body medication to help slow down the dementia. That's also a disease above the neck. But this stigma against anxiety and depression is the thing that gets in the way of people getting help for substance abuse, substance misuse.
Okay. Oh, Prof, thank you so much.
Yes, sir.
Yeah, it's been a wonderful time with you. We very educating us on this very vital topic. And I'm so sure that the viewers will find it very interesting and useful. And thank you also, Prof, for giving us your time. And especially thank you in advance for, for subsequent time with you, which I believe we'll have you very soon to talk on some other issues. We do really appreciate you. And
by the way, when you're in Finland,
yes, Prof.
If I can mention that you're going to Finland,
yes.
The third week in October, the university is sending me on a speaking circuit to Europe, the European Union. Really? So maybe we can meet in Germany or Poland. I'll just be there for 1 week.
Oh, okay.
And Finland is a bit north, but
yes.
But it's just a thought.
Yes.
One of the universities where I'll be giving speeches.
Really?
Maybe we can get together on one of those 7 days that I'll be there.
Yes, that is good. I will definitely keep in touch, Prof. Definitely keep in touch. Yes. So thank you so much, everyone out there, and thank you for, I believe that every one of you who will be watching this will also take a time to share the link and to actually make a comment or make recommendation of what you think we can talk about in our subsequent video. Our guest today has been Professor William Arthur Mosia. He is indeed an expert in all these topics we'll be discussing right away. And we have sought his consent, his permission to allow us have his email and his WhatsApp contact, so that for any one of you out there who wants to consult him, want to ask questions regarding some of these topics, you are actually free to do that. So you can do that via his email or his WhatsApp contact. He's always willing to help, willing to give to the society. I can really mention that over and over. Thank you so much, Professor Williams, for your time. I really appreciate you once again. Thank you.